Welcome back to the deep dive. Our mission, as always, is taking these really dense medical texts and breaking them down.
Making them make sense, right?
Exactly. Getting to the core insights you actually need without, all the jargon that can sometimes get in the way.
Mm-hmm.
Today, we're zeroing in on a very, very precise way the immune system can, well, backfire.
Antibody-mediated hypersensitivity,
Oh,
type 2,
type 2, yeah.
Yeah.
We've got a top-tier pathology text here as our guide.
our map, so to speak.
And the goal today, for you listening, is to really get under the hood, not just naming diseases, but understanding how these antibodies, which are meant to defend us, end up targeting our own fixed structures.
Yeah, and that's the core idea of hypersensitivity generally, isn't it? It's an immune response that's just...
Off how? Like too strong or...
It could be excessive, yeah, or poorly controlled, or, crucially for type 2, it's fundamentally misdirected. It's attacking self when it should be protecting.
Okay, so type 2, let's define that specifically.
Right. It is always, and this is key, antibody-mediated. That's the first thing.
Got it. Antibodies are the culprits.
And it kicks off when secreted antibodies, mostly we're talking IgG and IgM here.
The main workhorses.
Exactly. When they find and bind to antigens that are physically fixed.
Fixed, meaning stuck, not floating around.
Precisely.
What?
They're not soluble antigens drifting in the blood. They're anchored either right on the surface of a target cell, or they're actually embedded within the structural scaffolding of tissues, like the extracellular matrix. Think basement membranes.
Okay, so the antibody locks onto something stationary.
Yes. And this single event, this antibody binding to a fixed target, is kind of remarkable because it doesn't just cause one problem.
Ah, right. You mentioned it branches out.
It branches into three really quite distinct ways of causing disease, three different pathogenic pathways.
Okay, what are they? Lay them out for us.
So pathway 1 is direct destruction. The antibody tags the cell, leading to it being destroyed, either lysed open or eaten by other cells.
Phagocytosis.
Tag and destroy. Got it. Pathway 2 is more like collateral damage. The antibody binds in a tissue, and that triggers a massive localized inflammation that damages the surrounding area.
The accidental fire.
Good analogy, yeah.
Yeah.
And pathway 3 is maybe the most subtle, almost counterintuitive.
How so?
The antibody binds to a cell receptor, something important for signaling, and it either blocks the normal signal or it mimics it, hijacking the cell's function without actually killing it or causing inflammation.
Wow. Okay, so destroying, inflaming, or just interfering.
Interfering, yeah. Jamming the signals, essentially.
And these three mechanisms, they're behind some really serious conditions, right?
Absolutely. A huge range of autoimmune diseases fall under this. Things like certain anemias, transfusion reactions, muscle disorders like myasthenia gravis, even hormonal problems like Graves' disease.
Okay, that range really underscores why understanding the mechanism is so vital. It's not just one disease type.
Not at all. The mechanism dictates the pathology.
All right, let's dig into those mechanics then. Starting with mechanism 1, the most direct one, cell destruction. Okay, mechanism 1. We're calling this the tag and destroy method. The antibody acts like a flag, right? Marking a cell, often a blood cell, for elimination.
That's a perfect description. Once that antibody, again, usually IgG or IgM, binds to an antigen on the cell surface, that cell gets coated. It's effectively painted with the destroy me signal.
And the scientific term for that coating?
Opsonization. The cell is opsonized.
Opsonized. Okay, so the tag is on. What happens next? Who carries out the destruction?
Their primary executioners are the phagocytes. Think of them as the immune system's cleanup crew. Macrophages are the big players here.
Right, and how do they know which cells to clean up?
It's all about recognition. When an IgG antibody binds, its tail end, the OC portion, sticks out from the cell surface.
Okay.
Phagocytes, like macrophages, are studded with specific receptors called Fc receptors. These receptors are perfectly shaped to grab onto that exposed Fc tail of the IgG.
Like a hand.
Exactly like a handle. That binding action, Fc receptor to Fc tail, is the trigger.
Trigger for what?
For the phagocyte to basically engulf the entire antibody-coated cell. It pulls it inside itself into a little pouch, a vesicle.
And then digests it.
And then unleashes powerful enzymes to completely break it down. Destroyed from the inside.
Wow. Efficient.
Highly efficient. This is the main way the body gets rid of antibody-coated red blood cells, or platelets, for instance. Usually happens in the spleen and liver.
So IgG provides that direct eat-me signal via its Fc tail, but you mentioned IgM too, and the source material talks a lot about the complement system. How does that fit in?
Right, complement is huge here. It acts as a major amplifier, and it provides another tagging system working alongside or sometimes even instead of the direct Fc recognition.
And an amplifier. How does it amplify?
When IgM, which is particularly good at this, or IgG coats the cell surface, they can kick off what's called the classical complement cascade.
Cascade, like
Yeah.
dominoes falling.
Pretty much. It's a sequence of proteins activating each other. One activates the next, which activates many more, and so on. It snowballs.
And the end result of this snowballing.
The important result for phagocytosis is the generation of huge amounts of specific complement fragments, particularly C3b and C4b. These fragments literally get plastered all over the surface of the target cell.
Okay, so now the cell is coated in antibodies and these C3b, C4b fragments.
Exactly. And here's the clever part, or the redundancy, depending on how you look at it. Phagocytes don't just have Fc receptors for antibodies.
Well, let me guess, they have receptors for C3b and C4b too.
You got it. They have complement receptors as well. So a cell can be tagged by antibody alone, by complement alone, or, most powerfully, by both.
Double tag.
Double tag. Ensures robust recognition and pretty much guarantees that the phagocyte will grab it and destroy it.
So the net result is just rapid clearance of these tagged cells.
For rapid, highly effective clearance. That's opsonization and phagocytosis.
Okay, but complement doesn't just make tags, right? The source mentions the membrane attack complex, the MAC. That sounds much more aggressive.
Oh, it is. MAC formation is the, let's call it the nuclear option of the complement cascade.
Nuclear option.
Instead of just making tags for phagocytes, the final proteins in the complement cascade actually assemble themselves directly on the target cell's membrane.
Assemble into what?
Into a structure, a pore, called the membrane attack complex. Think of it like a molecular drill.
It drills holes in the cell.
Literally, it punches a hole right through the cell's outer lipid membrane.
And what does that do to the cell?
It's instantly catastrophic for the cell. The hole breaks the seal, disrupts the osmotic balance, water floods into the cell.
And it bursts.
It swells up and bursts. Pop. Osmotic lysis.
Instant destruction.
Instant destruction.
Yeah.
But there's a bit of nuance here, something important for, anyone studying this closely.
Okay.
While the MAC is incredibly powerful, it works best against things with relatively weak walls, like certain bacteria.
Not necessarily our own sturdy cells.
Our own cells often have ways to resist Enderwassy lysis to some extent, or repair the damage. So while MDC definitely contributes, especially in very acute situations, for many type 2 reactions involving our own cells, that steady, relentless clearance by phagocytes eating the opsonized cells is often the more dominant chronic mechanism of depletion.
Okay, that makes sense. Lysis is quick and dramatic. Phagocytosis is maybe slower, but very thorough.
Exactly.
Before we move to examples, there's one more destruction method mentioned. Antibody-dependent cellular cytotoxicity, ADCC. What's that about? It involves NK cells.
Right. ADCC is another way Ig-coated cells can be killed, but it doesn't involve phagocytosis being eaten.
So how does it work?
In ADCC, certain effector cells, mainly natural killer NK cells, but also macrophages, use their FTC receptors to bind to the IgG coating the target cell.
Okay, same binding as phagocytes.
Same initial binding. But instead of engulfing the cell, the NK cell or macrophage gets activated to release toxic molecules directly onto the target cell surface.
Like a direct hit, killing it from the outside.
Precisely. They release cytotoxic granules that induce the target cell to die, essentially. It's lysis, but mediated by direct contact with the killer cell, not by complement pores or ingestion.
Okay, another weapon in the arsenal. But how important is ADCC in these type 2 diseases we're discussing?
And this is where we need to be careful, reflecting what the source material itself says. The text is quite explicit that the actual contribution of ADCC to the common type 2 hypersensitivity diseases, like the autoimmune anemias we'll discuss, well, it's described as uncertain.
Uncertain, so we know it can happen, but maybe it's not the main driver in patients.
That seems to be the current understanding. It's a valid mechanism shown in labs, but in the context of many common type 2 diseases, the evidence points much more strongly towards complement and Fc receptor-mediated phagocytosis as the major pathways of destruction.
So we include it for completeness, but maybe keep it in perspective.
Exactly. It's part of the toolkit,
Yeah.
but perhaps not the primary tool used in many of these specific conditions.
Okay, that's really important context. Let's make this real now with examples. Where do we see this tag and destroy mechanism causing urgent problems? Transfusion reactions seem like the obvious start.
Absolutely. The classic rapid type 2 event. If you receive a blood transfusion and that blood has antigens on its surface that you already have antibodies against, the classic example is an ABO mismatch.
Like getting type B blood if you're type A.
Exactly. Your pre-existing antipeg B antibodies instantly latch onto those donor red blood cells.
And then what? All hell breaks loose.
Pretty much. Massive immediate complement activation occurs right there in the bloodstream.
So, MSC formation.
MC formation, causing intravascular lysis cells bursting open right in the vessels. Plus, massive opsonization leading to rapid phagocytosis by macrophages, mainly in the liver and spleen.
What does that feel like for the patient?
It's a crisis. Rapid destruction of all those transfused cells releases huge amounts of hemoglobin and cell debris into the blood. This can cause fever, chills, shock, back pain, and critically, acute kidney failure as the kidneys get overwhelmed. It's an emergency.
Minutes matter.
Absolutely. It's not a slow burn disease. It's immediate catastrophe.
Okay. A similar catastrophe, but happening before birth, is hemolytic disease of the fetus and newborn, also called erythroblastosis fetalis. What's the specific antibody detail that allows this?
The absolute key here is the antibody class. It has to be IgG.
Why IgG specifically?
Let's say you have an Rh-negative mother carrying an Rh-positive fetus. During pregnancy, or more commonly during delivery, some fetal red blood cells might enter the mother's circulation.
Sensitizing her.
Sensitizing her, exactly. She might develop anti-Rh IgG antibodies. Now, in a subsequent pregnancy with another Rh-positive fetus.
The IgG crosses the placenta.
Yes, IgG is the only antibody class small enough and equipped with the right transport mechanism to actively cross the placenta from mother to fetus. IgM, for instance, cannot cross.
So the mother's anti-Rh IgG gets into the baby's blood.
Correct. Once in the fetal circulation, that maternal IgG binds to the baby's Rh-positive red blood cells, opsonizing them.
Tagging them for destruction by the baby's own immune system.
By the baby's own macrophages in their spleen and liver. This leads to widespread destruction of fetal red cells, causing severe anemia, jaundice due to bilirubin buildup from broken down hemoglobin, and can even lead to heart failure and death if untreated.
Again, driven by Ig-mediated opsonization and phagocytosis?
Precisely.
Okay, so those are reactions to foreign cells in a sense. What about when the body attacks its own blood cells? True autoimmunity.
Yes, that brings us to things like autoimmune hemolytic anemia, AIHA, or similar conditions targeting white blood cells, granulocytosis, or platelets, immune thrombocytopenia, ITP.
Let's take ITP, attacking platelets. What's the target there?
In many cases of ITP, the autoantibodies target specific proteins right on the platelet surface. A common target is a protein complex called GPII.3 integrin, which is crucial for platelet function.
So the antibody binds to this vital platelet protein.
Binds to it, opsonizes the platelet, and then macrophages, again primarily in the spleen, recognize that antibody tag via their Fc receptors and gobble up the platelets.
Leading to low platelet counts.
Exactly, thrombocytopenia. And since platelets are essential for blood clotting, the patient experiences easy bruising, bleeding gums, and potentially dangerous internal bleeding. It's pure destruction of a circulating component.
And finally, in this destruction category, how can drugs trigger this, making our own cells look like targets?
Drugs can do this in a couple of really interesting ways. First, a drug molecule might be too small on its own to trigger an immune response. It's called a hapten.
Okay.
But this haptens can bind firmly to a protein on the surface of one of our own cells, say a red blood cell.
Creating a new combined structure.
Exactly. A drug-protein complex. The immune system might now see this complex as foreign. Even though the cell protein itself is self, it mounts an antibody response against the complex.
And when those antibodies bind?
They opsonize the cell carrying the drug complex, leading to its destruction via phagocytosis, or complement. The drug essentially hijacks the cell, painting a target on it.
That's one way. What's the other?
The other way is that the drug might actually chemically modify an existing protein on the cell surface. It changes its shape slightly.
Creating a new epitope, a new antigenic site.
Precisely, a neoantigen. The immune system sees this altered self-protein as foreign and makes antibodies against it. Again, the end result is the destruction of the host cell that displays this neoantigen.
So whether the drug adds something or changes something, the cell ends up tagged for destruction.
That's the bottom line for drug-induced type 2 reactions.
Okay, that covers the tag and destroy pretty thoroughly. Let's shift gears now to mechanism 2. We call this the accidental fire. The big difference here, you said, is the target isn't a circulating cell. The antibodies are binding to fixed structures like basement membranes and tissues.
Exactly. Not mobile cells, but parts of the tissue architecture itself.
And the damage isn't from killing the structure directly, but from the inflammation the antibody triggers around it.
That's the key distinction. The antibody binding acts like a homing beacon, but instead of just calling in phagocytes to eat one cell, it triggers a massive inflammatory response right there in the tissue.
And complement is central to this inflammation story, too.
Absolutely central. When antibodies, again IgG or IgM, deposit on something like a basement membrane in the kidney or lung, they activate complement right there, locally.
Kicking off that cascade again.
Kicking off the cascade. Now remember, complement evolved primarily to fight microbes, but here it's being activated against their own tissue matrix.
So the signals it sends out cause
Yeah.
friendly fire.
Precisely. Collateral damage.
Yeah.
The complement cascade generates several byproducts that are powerful pro-inflammatory signals.
Which ones are most important here?
For driving inflammation, the really key ones are potent signaling molecules called chemotactic agents. The main one is C5a.
C5a, chemotactic, meaning it attracts cells.
Yes, it's like a chemical siren. C5a powerfully attracts inflammatory cells, specifically neutrophils, a type of granulocyte and monocytes, drawing huge numbers of them out of the bloodstream and right to the spot where the antibodies and complement are deposited.
So the antibody is stuck, complement gets activated, C5a screams for help, and an army of neutrophils arrives.
That's the sequence. But complement does more than just call for backup.
What else?
The source also highlights anaphylotoxins. Both C3a and C5a act as anaphylotoxins.
The anaphylotoxins, what do they do?
They act on local blood vessels, making them leaky. They increase vascular permeability.
Why is that important?
It opens the floodgates. It makes it easier for fluid to leak out into the tissue, causing swelling. But more importantly, it helps those recruited neutrophils and monocytes squeeze out of the blood vessels and actually get into the tissue where the antibody deposit is located.
So C5a calls them in, and C3a, C5a help them get there. Sets the stage for the fire.
Perfectly put. It primes the tissue for a massive influx of inflammatory cells.
Okay, so now we have this mass of neutrophils and monocytes crowded around the antibody deposit.
They get activated, right? How?
They get activated because they have receptors for the complement fragments like C3b that are coating the area, and also Fc receptors if IgG is involved. Binding to these triggers their activation.
And an activated neutrophil is dangerous.
Very dangerous to surrounding tissue when inappropriately activated like this. They are packed with destructive weaponry designed to kill microbes, but here they unleash it onto the host's own matrix.
What kind of weaponry are we talking about? What's the payload in this accidental fire?
It's basically chemical warfare against the tissue. Once activated, these leukocytes, especially neutrophils, release the contents of their granules. This includes powerful lysosomal enzymes.
Like what?
Proteases, collagenoses, elastases, enzymes designed to digest proteins and connective tissue. They don't care if it's a bacterium or your own basement membrane, collagen, or cartilage. They just start dissolving the structural components of the tissue.
Ouch. Dissolving the tissue itself. And that's not all. They also undergo what's called an oxidative burst, rapidly generating and releasing huge amounts of reactive oxygen species, ROS.
Free radicals.
Exactly.
Yeah.
Highly reactive molecules like superoxide radicals and hydrogen peroxide. These cause direct chemical damage oxidation to lipids, proteins, DNA, basically burning the tissue at a molecular level.
So enzymes dissolving the structure and ROS burning it, that sounds incredibly destructive.
It is. This combination of enzymatic digestion and oxidative damage is the essence of the inflammatory tissue injury in this type of type 2 reaction.
And the classic example, the textbook case that perfectly illustrates this mechanism.
Goodpasture syndrome. It's the prototype for antibody-mediated inflammation against a fixed tissue antigen.
What makes it so prototypic? What's the target?
In Goodpastures, the autoantibodies are incredibly specific. They target a particular protein, a non-collagenous domain of type IB collagen, which is a critical structural component found only in the basement membranes of two main places, the kidney glomeruli and the lung alveoli.
So a very specific target in very specific vital locations.
Exactly. These are delicate structures designed for filtration, kidneys, and gas exchange, lungs. They absolutely depend on the integrity of their basement membranes.
Well, the antibody binds in the kidney and lung basement membranes.
The complement gets activated there. C5a calls in the neutrophils.
And the neutrophils arrive and dump their enzymes and ROS right onto those delicate membranes.
Correct. The result is severe, rapidly progressive inflammation in both organs.
Leading to?
leading to glomerulonephritis, inflammation and destruction of the kidney's filtering units, causing kidney failure, and simultaneously pulmonary hemorrhage bleeding into the air sacs of the lungs because the basement membranes there are being destroyed.
Wow. Kidney failure and lung bleeding, all from antibodies sticking to basement membranes and calling in the inflammatory troops.
It's a devastating illustration of mechanism too. The antibody itself doesn't kill anything directly, it just initiates the inflammatory cascade that ravages the tissue.
Okay, we've covered direct destruction and inflammation-driven damage. Now for the third mechanism, the signal jammer.
Yes, pathology through functional interference.
This one feels different. You said the cell isn't necessarily destroyed and inflammation might not be the main issue?
Often, yes. The damage here is much more subtle, at least structurally. The antibody causes disease simply by binding to a functionally important molecule on the cell surface, usually a receptor, and messing up its normal job.
Messing it up how? By blocking it.
That's one way. Blocking the receptor, preventing the normal signal from getting through. Or sometimes the antibody binding actually mimics the normal signal, turning the receptor on when it shouldn't be.
So it can either block or activate.
Exactly. Either way, it disrupts the cell's normal physiological function, leading to disease, even if the cell itself looks perfectly healthy under a microscope.
It's like molecular sabotage.
That's a great way to put it.
Let's start with the blocking scenario. Inhibition. The classic example is myasthenia gravis, right?
The absolute classic.
Yeah.
In myasthenia gravis, the problem is at the neuromuscular junction where nerves talk to muscles.
Okay.
The autoantibodies specifically target the acetylcholine receptors, AChRs, which are located on a muscle cell membrane at this junction.
And acetylcholine is the neurotransmitter, the signal molecule.
Correct. The nerve releases acetylcholine, it crosses the tiny gap, the synapse, and binds to these AChRs on the muscle. That binding is the signal that tells the muscle to contract.
So what does the antibody do?
The anti-AChR antibody binds to the receptor, and it basically just sits there. It physically blocks acetylcholine from binding.
Like putting chewing gum in a keyhole.
Excellent analogy. The key, acetylcholine, can't get into the lock, the receptor, because the antibody is in the way.
So the signal transmission fails.
Signal transmission is inhibited. The muscle doesn't get the contract message effectively. Over time, the number of functional receptors can also decrease due to antibody-mediated internalization and degradation.
And the result for the patient?
Progressive muscle weakness. It often starts with muscles controlling the eyes and face, leading to droopy eyelids or double vision, difficulty swallowing, and then can progress to generalized weakness, fatigue, and in severe cases, respiratory failure. The muscle tissue itself isn't destroyed initially, but its function is profoundly impaired.
Pure signal jamming leading to paralysis. Okay.
Well, weakness progressing towards paralysis in severe cases, yes.
So if myasthenia jams the signal off, what's the example where the antibody jams the signal on?
That would be Graves' disease, the most common cause of hyperthyroidism.
Hyperthyroidism over active thyroid. How does an antibody cause that?
In Graves' disease, the autoantibodies target a different receptor, the receptor for thyroid-stimulating hormone, TSH, which is found on the surface of thyroid follicular cells.
And TSH is the hormone from the pituitary gland that normally tells the thyroid to make thyroid hormone, right?
Exactly. TSH binding to its receptor is the on switch for thyroid hormone production.
So does the Graves antibody block this receptor, like in myasthenia?
No, it does the opposite. The antibody in Graves' disease is shaped in such a way that when it binds to the TSH receptor, it activates it. It mimics the action of TSH itself.
So it's like a fake key that turns the ignition on.
A fake key that gets stuck in the on position. The antibody provides constant, unregulated stimulation of the thyroid cells, completely independent of the body's actual need for thyroid hormone, or the normal feedback loops controlled by the pituitary.
So the thyroid just keeps churning out hormone.
Keeps churning out excessive amounts of thyroid hormone, thyroxine and triiodothyronine. This leads to the symptoms of hyperthyroidism. Rapid heart rate, weight loss despite increased appetite, anxiety, tremors, heat intolerance, sometimes bulging eyes, exophthalmos.
Again, the thyroid cells aren't necessarily being destroyed.
Not primarily. They're just being pathologically overstimulated by an antibody acting like a rogue hormone.
This contrast is amazing. Same basic mechanism, antibody binds receptor, but opposite functional outcomes. Paralysis versus overdrive.
It really highlights how the specific effect of the antibody binding, blocking versus stimulating, dictates the entire clinical picture. It's all about the function.
Okay, let's cover a couple more examples of this functional derangement. Pernicious anemia. How does that fit? It sounds like an anemia which usually involves destruction.
But the cause here is functional interference, specifically with absorption. In pernicious anemia, the autoantibodies don't target blood cells directly. They target intrinsic factor.
Intrinsic factor, what's that?
It's a protein secreted by parietal cells in the stomach lining. Its job is absolutely essential. It binds to vitamin B12 that we get from our diet.
Why does B12 need binding?
This intrinsic factor B12 complex is required for vitamin B12 to be absorbed later on, down in the small intestine, the ileum. Without intrinsic factor, you basically can't absorb dietary B12 effectively.
So the antibodies attack intrinsic factor.
Yes, they bind to intrinsic factor and neutralize it, preventing it from binding B12 or preventing the complex from being absorbed.
Blocking its function?
Blocking its function. So no B12 gets absorbed. And vitamin B12 is crucial for making healthy red blood cells.
Ah, hence the anemia.
Exactly. Lack of B12 leads to impaired DNA synthesis, which affects rapidly dividing cells like red blood cell precursors in the bone marrow. They become abnormally large and can't mature properly, resulting in megaloblastic anemia. It also causes neurological problems because B12 is vital for myelin maintenance.
So the root cause isn't red cell destruction by antibodies, but failure of B12 absorption due to antibodies neutralizing intrinsic factor.
Correct. Functional blockade leading to deficiency and downstream consequences.
One more, pemphigus vulgaris. This causes skin blistering, which sounds like destruction, but you're saying it's functional.
It's dysfunction at the level of cell-to-cell adhesion. It's about disrupting the glue that holds skin cells together.
What's the target?
In pemphigus vulgaris, the autoantibodies target proteins called desmogleins. These are key components of desmosomes, which are like molecular rivets or spot wells that anchor epidermal cells, keratinocytes, firmly to each other.
So antibodies attack these rivets.
They attack the desmoglein proteins within the rivets. The source notes that this antibody binding seems to activate intracellular proteases.
Enzymes that break things down.
Right. These activated proteases then degrade the desmosomal proteins, effectively dissolving the connections between the skin cells.
The cells just come apart.
They lose their adhesion to one another. This separation within the epidermis, called a cantholysis, leads to the formation of fluid-filled blisters, bullae. The skin essentially falls apart structurally.
So it's not inflammation burning the skin or direct cell killing, but the antibody interfering with the adhesion mechanism, causing structural failure.
Precisely. Dysfunction of intercellular adhesion. It fits firmly under this third mechanism of functional alteration. #tag advancements and broader context of type 2.
Okay, we've mapped out the three distinct mechanisms: direct destruction, inflammation, and functional interference. Stepping back now, what's the big picture theme that emerges when you look at all these type 2 examples?
Well, one thing that just jumps out is how many of these classic type 2 diseases involve autoantibodies.
Antibodies against cells.
Exactly. When you list them, myasthenia gravis, Graves, Goodpasture's, autoimmune hemolytic anemia, pemphigus, pernicious anemia, these are benchmark examples of autoimmunity.
Which fundamentally means a breakdown in
Self-tolerance. The immune system's ability to recognize its own components and not attack them has failed. It's mistakenly identified self-antigens receptors, basement membrane proteins, cell adhesion molecules as targets for destruction or interference.
And going back to those three mechanisms, thinking about them together is really crucial, isn't it? Especially for how you'd even think about treating these conditions.
Oh, absolutely monumental. The distinction between mechanism 2, inflammation, and mechanism 3, functional change, has huge therapeutic implications.
How so? Use Goodpasture's and Graves again.
Okay. Goodpasture's is mechanism 2. The damage comes from that accidental fire neutrophils releasing enzymes and ROS onto the basement membrane. So how do you treat it?
You have to put out the fire, stop the inflammation.
Exactly. You need powerful immunosuppressive drugs to reduce antibody production, maybe plasma exchange to remove existing antibodies, and critically, strong anti-inflammatory therapies like corticosteroids to shut down those destructive neutrophils.
Okay. Now, Graves' disease. Mechanism 3. Overstimulation of the TSH receptor. Would anti-inflammatories work there?
Not really, or at least not for the core problem. The thyroid isn't being damaged by inflammation, it's being functionally overdriven by the stimulating antibody.
So you need a different approach entirely.
Completely different. Treatment for Graves focuses on stopping the consequences of the stimulation. You use drugs that block the thyroid's ability to synthesize hormones, like methimazole or propylthiouracil, or beta blockers to control the symptoms like rapid heart rate. Or, more permanently, you might use radioactive iodine to destroy thyroid tissue or surgically remove part of the gland, effectively reducing the number of targets for the antibody.
Wow. So the treatment strategy is dictated entirely by whether the antibody causes inflammation or functional change.
It's proof positive that these mechanistic distinctions aren't just academic, they are clinically vital. The type 2 classification really captures these fundamentally different ways an antibody can cause pathology.
It also seems like we quickly moved from reactions to foreign antigens, like in transfusion reactions or HDFN,
Right, triggered by non-self.
to the majority of examples being truly autoimmune, triggered by self-antigens.
Yes, and the source material kind of uses type 2 to bridge that gap. It shows how the same immune effector mechanisms, opsonization, complement, SC receptors are employed, whether the initial trigger is foreign blood group antigen or a self-receptor like the AChR. The constant factor is the antibody binding to a fixed target.
And the incredible specificity we talked about, where that fixed target is located determines everything.
It's the ultimate lesson in biological geography, isn't it?
What do you mean?
If the antibody targets intrinsic factor, a soluble protein needed for B12 absorption, you get pernicious anemia, a metabolic disease.
Oh.
If it targets desmoglein, a protein holding skin cells together, you get pemphigus vulgaris, a blistering skin disease.
Right.
If it targets the acetylcholine receptor at the neuromuscular junction, you get myasthenia gravis, a disease of muscle weakness. If it targets the TSH receptor on thyroid cells, you get Graves' disease and endocrine disorder.
Same class of immune reaction, wildly different diseases based solely on the target's identity and location.
The immune system homes in with exquisite specificity, and the clinical outcome is entirely dependent on what that target does and where it is.
You know, we touched on ADCC earlier, antibody-dependent cellular cytotoxicity, and the text said its contribution was uncertain. Why do you think they even include it if its role seems minor in these classic type 2 diseases? Does that hint at something we don't fully understand yet?
That's a really sharp question. It gets at how these texts are built. When a mechanism like ADCC is included but its clinical weight is downplayed, it usually reflects the state of research, meaning, one, the mechanism itself, NK cells killing IgG-coded targets via Fc receptors, is well established in experimental settings. It definitely can happen. But two, when researchers look at patient samples or disease models for things like AI-Shay, the evidence for massive cell clearance overwhelmingly points to phagocytosis in the spleen and liver, driven by FDC and complement receptors.
So ADCC might be happening, but it's drowned out by the other mechanisms.
It could be a minor player, yes. Or perhaps it's more important in specific, less common type 2 scenarios that aren't the main focus, or maybe in certain phases of the disease, including it keeps the biological possibility on the table.
Acknowledging the complexity.
And acknowledging that our understanding is always evolving.
Hmm.
Maybe future research will uncover a more significant role for ADCC in certain contexts. For now, it's presented as part of the potential toolkit, but not the primary driver for the core examples we've discussed.
Okay, that makes sense. So we've covered the molecular drill of MSC, the chemical fire of neutrophils, the silent sabotage of receptors. Quite a range for one hypersensitivity type.
It really is. So to wrap up the key points for everyone listening, type 2 hypersensitivity is antibody-driven, IgG, IgM, against fixed antigens, on cells or a matrix. This leads down three paths.
Path 1.
Targeted cell depletion, mainly via opsonization, coding with antibody Fc and or complement C3bC4b, followed by phagocytosis. Direct lysis by the MSC can also contribute, especially acutely. ADCC is a possible but maybe less prominent contributor.
Path 2.
Localized tissue damage via inflammation. Antibody deposition activates complement. C5a recruits leukocytes, especially neutrophils, which then release destructive enzymes and ROS, causing collateral tissue damage. Think good pastures.
And path 3.
Cellular dysfunction without destruction. Antibodies bind to functional molecules, usually receptors. They either block normal signaling, like anti-AChR antibodies in myasthenia gravis, or they inappropriately stimulate signaling, like
Well, that brings us to the end of this deep dive into type 2 hypersensitivity. It's really quite something, seeing how a single type of molecule, an antibody, binding to a fixed spot can lead to such radically different outcomes from, the immediate crisis of a transfusion reaction to the chronic signal jamming that underlies diseases like myasthenia or Graves.
It truly demonstrates the power and the potential pitfalls of such a specific biological interaction. And that leads me to a final thought, something for you, the listener, to maybe ponder.
Okay.
We've identified these key targets: the acetylcholine receptor, the TSH receptor, basement membrane proteins, intrinsic factor, desmogleins. These are all critical molecules whose functions we relatively speaking, understand quite well.
Right.
But think about the vast complex network of other receptors, signaling molecules, adhesion proteins, and matrix components that exist throughout our body, governing countless physiological processes, many of whose functions might still be poorly understood or even completely unknown.
Okay. Where are you going with this?
What are the chances that there are other type 2 hypersensitivity diseases out there right now caused by autoantibodies targeting some of these other less well-characterized or currently unidentified functional molecules or structures?
You mean the list of type 2 diseases we know might just be the tip of the iceberg? Limited only by what targets we've managed to identify so far.
Precisely. Could there be subtle, chronic diseases driven by antibodies interfering with obscure signaling pathways or structural components that we simply haven't linked back to a type 2 mechanism yet? It's a fascinating and slightly unsettling possibility to consider. The potential scope of this mechanism might be far broader than our current catalog of diseases suggests.